requesting all the participants, panelists, and the chairperson to take the seat. I am requesting Professor Dr. Shahabuddin sir to come to the dais.
Okay, off.
Professor Dr. Shahabuddin sir. And I am also requesting Dr. Shomir Kumar Kundu to come to the dais.
Very good morning, Dr. Ryan. Can you hear me?
Yes, perfectly.
Thank you and welcome from BSCI International Conference 2022. This is our last live case by you. So we are here with me and my co-moderator, Dr. Bijoy Dutta. We have learned panelists and chairpersons are Professor M. Jalaluddin, Professor Hasina Banu, Professor Abdul Qadir Agant, Professor Moinuddin Ahmed, Professor Min Nesaruddin Ahmed, and Professor Shahabuddin sir. And the panelists are Professor Abdur Rauf, Pradip Kumar Karmakar, Mizanur Rahman, Shafiqur Rahman Patwari, and Khobiruddin Ahmed. So please introduce your Cath lab team and start your case.
Good morning. It's really nice to be part of your Congress, and I heard you already worked many days, so thank you for staying with us also at the very end.
Sir, Khalid Mashin sir, please come to the dais.
I think, well, we are happy that Humanitas can take part of your Congress. Afterwards, I will introduce the team. Antonio now will introduce the case, which I think is quite an interesting case for you.
Hi, Dr. Reimers. This is Dr. Bijoy from Bangladesh. Can you hear us?
Yes, very well.
Oh, please.
We want to show the first slide.
Okay.
Okay. Can you hear also Dr. Mangieri, who wants to introduce the case?
Yes.
Okay, try to. No. Okay. So Dr. Mangieri will speak to my microphone. Okay.
Hello, good morning, everybody. So briefly, we just introduced the case. He's an 82 years old male who came to our attention because of a recent hospitalization for acute heart failure. Here you see in the first slide the diagnostic test that we did. So it's important to note how high is the BNP, and the echo, what the echocardiographists found was a severe reduction of the ejection fraction with a low flow, high gradient severe aortic stenosis with a mean gradient of 40, an aortic valve area of 0.4, and a concomitant moderate mitral regurgitation. If we can go to the next slide, please. Here you can appreciate the echo. You see how hypokinetic is the echo without any alteration of the segmentaria kinesis, but I would say that is a diffuse hypokinesis. Here you can appreciate in 4 chambers, but as well also in the 2-chamber view, we confirmed the severe reduction of the ejection fraction. And go to the next step, please. Also in the 3-chamber view, maybe the septum is a little bit more hypokinetic. So next slide, please. Here we confirmed that the high increase of the gradient, and you see that the peak-to-peak velocity is more than 4 meters per second. And go to the next slide. And we did also CT scan to better evaluate the valve, and we took some measures because we will briefly introduce how we planned the case. And you see here that the valve area is pretty large with a perimeter of 82 and a minimum diameter of the annulus of 23. And if we move to the next slide, you see how much calcium there is and what is the high also of the coronaries. So next slide, please. Basically, this patient was planned for an aortic valve replacement. Next slide. And these are the axes as well, which are quite nice. There is some mild tortuosity in both levels. I think maybe it's a little bit more hinked at the level of the left system. But if we go, we did also a baseline coronary angio to better understand if the hypokinesis was secondary to a valve dysfunction or secondary to a coronary artery disease. And you see here that the RCA is not pretty developed, but there is for sure severe stenosis in the proximal segment that maybe we can consider for medical therapy. But if you go to the next slide, you see that basically the left main is, I would say, moderate to severe 50% stenosis in the distal portion with a concomitant severe disease of the LAD at the bifurcation with a big first diagonal branch. And there is also a dominant circle with a severe stenosis in the mid-distal part. So, next slide. Here you see also in the cranial view as well how tight is the lesion on the LAD at the bifurcation of the diagonal, and both the branches are involved with a severe disease. So basically, next slide, I think we have finished. So our plan is to basically proceed with a coronary vascularization using the new abluminous DES, and also if we have the possibility also to treat in a hybrid fashion using also the new drug-coated balloon by Concept Medical, the Magic Touch 1. So I think, Bernhard, maybe we can move inside of the Cath lab and better explain what is on.
So the patient actually, we did yesterday evening the coronary angiography. So we decided yesterday that we want to share this case with you because it's, I think, a very interesting case, and we had to do him today anyhow. So low flow, low gradient, severe aortic stenosis. But also a severe disease of the coronaries, 82 years old, no, 83. So we have to, not so old, so he still has some life expectancy. He's working in his vegetable garden every day, and now less because he had shortness of breath. What I did so far, what we did so far, we have quite a few we have from the groin, the right groin, 14 French sheet, which was pre-closed with 2 proglides. We have a 4 French in the left groin, in the artery for safety reasons, and a vein also in the right groin. Puncture was quite easy. We crossed the valve. Was not so difficult, and now you can see here live. We have a multi-purpose guiding catheter in the left ventricle. Can we see also the EKG and the pressure traces, please? Is this possible? È possibile vedere le tracce? Okay. And to make a long story short, we want to position an impeller device. We want to do balloon valvuloplasty because he came in for probably his aortic stenosis. And then we want to take care of the coronary arteries with the impeller still in place. Maybe now we position the impeller device and you continue to or give your comments. We have a Nova stiff wire for the valvuloplasty, 035, and here we have the wire for the impeller device, which both will be positioned in the left ventricle. But give me your comments while I continue to work, please. Can you hear me?
Yes.
I do not have any return.
This patient appears to have at least a moderate aortic stenosis with a advanced coronary artery disease. So did you consider a surgical aortic valve replacement and a CABG for this patient in the same setting?
He has 20% of ejection fraction. No way.
The surgeons rejected, I think, the patient.
Yes, well, we didn't show them even. We decided everything yesterday, so we did not show because there is no reason. You can see also the gradient. Have you seen before? Yes. Okay, now I go out with this is a 6 French guiding catheter, 2 wires in the left ventricle, one for the valvuloplasty, one for the impeller device. Okay.
Thank you, Dr. Reimers. Are you hearing me?
Yes, very well, thank you, and
I am
clear.
Professor Mir Jamal, Secretary
Hi,
General,
ciao.
Bangladesh Society of Cardiovascular Intervention. You are well?
Yes, thank
My
you.
question is that it's a low flow, low gradient, severe aortic stenosis, severe LV systolic dysfunction with multivessel disease. But your plan is to do first
We go with the impeller first.
valvuloplasty and then coronary angioplasty.
Yes.
Why?
Both with impeller support.
That's right, but I think if I do not revascularize first, then during aortic valvuloplasty, I shall have to make the heart rate high. That may cause further deterioration of the coronary supply, which may cause cardiac arrest or some form of arrhythmia. So my idea is to do first revascularization and then aortic valvuloplasty. What is the harm to do in this way?
Yes, you are very right. We discussed it this morning also with Dr. Colombo, Antonio Colombo, who is here. But he came for aortic stenosis. Please, ok, ce l'hai? Che tieni tutte e due le guide? Ops, cazzo. Ok, no, non era una buona idea questa.
No.
Sorry, I have a little... With tough time... No, qua dobbiamo... Okay, the 035 wire through the central hole and the impeller device together is not so easy. Now it's very comfortable. It's only the initial part of the impeller device, the wire a bit.
Yeah.
Questo indietro, no?
Vieni.
Questo non abbiamo bisogno.
No.
Which is very big. So we had a little bit of tough time. Okay, we can nicely see the aortic valve, and now we have the impeller inside. We removed the impeller wire.
Okay.
Okay, let's come back to your, I wasn't sure this morning. I don't know, we still can change. But now we have the wire here in the aorta.
Un pochino indietro l'impella, penso.
We start to
Perché siamo...
work with the impeller, yeah, okay, I think that's a good position.
Ok. Start with impella.
So you say you are afraid to do the balloon angioplasty with rapid pacing with the coronary artery disease right now?
Yes.
Have you experience in this? Because
it is 82 years patient, right, Reimer?
82 years.
Right, number one. Number two, the symptom due to aortic valvular disease or due to coronary artery disease?
aortic valvular disease, dyspnea, and low ejection fraction, but that's a very tight valve, of course.
Ejection fraction is reduced due to coronary artery disease, hopefully, not due to
We don't know,
valvular disease.
probably. It's actually diffuse hypokinetic.
Andiamo col pallone?
Yes.
Proviamo. Ok, andiamo col pallone.
Okay. I think tonight or yesterday I agreed with you that we want to do first the coronaries and then the balloon. This morning we decided the other way around. I don't think that we have really data. Hopefully we will not have any bad arrhythmias as you fear. But the coronary heart is very, very stable. Now we have the impeller device at how many liters?
It's 3.4.
3.4, okay, quite a bit. I have to keep the impeller device nicely. The balloon goes up okay-ish. I hope we can get it out afterwards.
Ok.
No, I don't like this. We have to puncture. Okay, we go out. Wait.
Reimers, are you doing the balloon as a palliative procedure with a staged TAVR in the next sitting?
Yes, scheiße. Adesso abbiamo fatto cadere. Trovo un altro impella?
Un altro impella. Trovate un altro impella. Allora, aspetta un attimo. Io ti tengo l'impella e tu tiri via quello lì. Aspetta. Ok.
So, what we learned, do not get in the same hole the balloon up. So what we do now is to do your plan. We do the coronary, we puncture the device, we get rid of the valve. Can you give me a 4 French, un 4 French multipurpose? 1 metro. We get rid of this wire. We remove the wire from the ventricle. It's already removed.
Sì.
And we do the coronary, so at the end we follow your plan. And we puncture with an 8 French the membrane of our impeller device and do afterwards the balloon valvuloplasty. Okay? No. Okay? So you are happy, we are happy too. LXP 3 mezzo, un introduttore 8 French.
Can you hear us? Io non sento niente. Tu li riesci a sentire?
No.
Ok. Ci date un agochimal?
Un ago cordes ce l'abbiamo, no? Ago cordes ce l'ho.
Poi per lavorare più comodo vuoi un destination lungo?
No,
perché
non ci sta, dopo non riusciamo
a
togliere. Un po' di acqua?
Sì. Ma questi io non sento niente.
Una guida?
Una guida standard? Sì.
Ma anche questa, no? O no?
Sì, è meglio, è più sicura quella lunga, Bernhard, perché così.
Can you hear me? I puncture here at 12 o'clock.
Yes.
Yes, we are hearing you.
I puncture the membrane. Put the wire. Okay. The 8 French introducer. Mi prepari un altro paio di guanti? We use an 8 French because this is then big enough to afterwards do the balloon valvuloplasty. Okay. Look at the impeller device. So this is much easier. And now we have 2 entrances. Okay, some water. XP 3.5, 3.5.
XB.
Ok, mi devo un attimo cambiare. I have to change my gloves.
Guide ne abbiamo? Dacci anche una
So have you
Sion.
seen the coronary arteries? What would you
Apri.
treat?
Aprissimo.
Left main,
No, non
LAD and circ. Which arteries?
Vieni Bernhard.
Questo è una B&W, ce l'abbiamo sotto. Perfetto. Sì.
Sì.
Non compliant 3030. 20. Semi-compliant. Altri 3000.
Facciamo uno spurgo. Microtest.
Piccolo test ancora. Ok. Pressure is not dumping. The guiding catheter pressure is the yellow one, okay? But obviously, now we have all this impeller support. I do one film for you. 4-4, 3-3, 5-4-4.
Okay.
Okay. So you can call it a bifurcation lesion.
DMV.
You agree?
Definitely.
1-1-1.
Yes.
And here we cannot lose anything.
That's right, but you see the side branch diagonal lesion is not crossing the even 5 millimeter from the ostium.
Yes, that's the only good news.
Yes, that is the good news.
LAD is long, but diagonal is short. So there's some hope. We definitely start with provisional if you agree.
You can do provisional stenting with gel balloon technique in diagonal.
No, I don't use this technique.
So, Reimers, so I think, have you changed your strategy from your initial strategy?
Yes, because the balloon did not go through the
Aortic valve.
valve of the introducer of the impeller. And I don't want to get into mischief. So we do the coronaries, then we do the valve, and then if we lose the impeller, we are a little bit, because maybe we don't need it anymore after balloon valvuloplasty.
Yes.
Because the plan is, of course, to get rid of the impeller here.
So,
So
now you're planning for
we
plan
followed
B.
your advice.
Coronary is first. Coronary is first, and then your impeller may not be necessary.
Yes.
Due to the low aortic valve area of 0.4,
Yes.
could you have thought about intra-aortic balloon pump instead of impeller?
Yes, but definitely much less protected. And if we then have a lot of balloon insufficiency after the valvuloplasty, it doesn't help us. Here with impeller there after balloon valvuloplasty, if we need to do bailout TAVI, we do everything
di curva per andare nel
much
diagonale.
more safe, I would say. You could do, but I think impeller here is safer. And having all in one axis, it's actually okay. It's not the 8 French of balloon plus another 7 in another groin or in the radial. Here you have single access, so it's not so much invasive, so much more invasive with the impeller compared to balloon with 2 axes. If you agree, right? So here I'm a diagonal. Dr. Colombo came.
Oh, hello. Sorry.
Okay. So good morning, Colombo. Welcome to you all from Bangladesh Society of Cardiovascular Intervention. Reimer, can you tell him
Because
we
the
are
balloon did
welcoming?
not go up.
We are welcoming Antonio Colombo for our live case. Okay.
Yes, because this morning we decided to go. Piccolo test.
But the vision is worse from the one I saw in Canada.
From yesterday, yeah, there was a lot of progression tonight.
There is a lot of progression. The best is the progression.
Yeah. Yeah.
This is difficult to explain. Mi dai il pallone?
Pallone.
So now we predilate towards both directions.
So what is your strategy regarding this case, this bifurcation lesion? Single stent strategy or
Predilate both lesions, confirm that we try to go for provisional. If there is a lot of dissection and we may have to change to DK crush. Okay, here we have to go a little bit more down in the LAD, go.
But Reimer, it is told that if you do not want to enter into the side branch with a stent, or meaning that you want to do provisional stenting, then it is better not to touch the side branch with a balloon.
Yes, I don't know. I'm not so sure about this. Okay. We'll see after the LAD predilatation, okay?
If I have an idea to do double stent strategy, only then usually we predilate the side branch.
Yes, I know. We had a live case for Jim on Tuesday. We didn't do dilate the diagonals, and then we had to start 2 diagonals. So,
you know, Reimer, actually what you want to say, this strategy, either if you go for upfront double stent strategy, then you can consider side branch balloon predilation.
Should be dilated. Otherwise, usually, if I do not.
But here he is doing only predilatation in the LAD.
LAD.
So
LAD.
Yes.
And it's dissected towards the diagonal.
Yes, it is dissected.
That's why he is thinking from the very beginning upfront double stent strategy, but in the aim to make it simple provisional strategy.
Now
ok, mi dai un altro 3-0. O 2,5, 2,5.
Allora la Sion è quella dell'IVA.
Sì, ok. So, now what we do a kissing
prima è questo.
Predilatation.
Quello che abbiamo usato prima. Sì.
A kissing predilatation.
Yes.
And then we ask you and we ask Dr. Colombo, Dr. Ferrante.
Okay.
This result is certainly for a stent.
Of both branches?
No, maybe first I will do the LAD, and then I will be kissing and then evaluate.
Yeah. Still provisional, okay.
But then the fact that the dissection is good, it means the decision is well prepared.
So what we trying now, Antonio, questo è il 3-0 ancora? È non compliant? No, semi. Oops.
Ce vuole uno nuovo, dai.
Sì, mi dai.
A new one we need.
Yes.
Non serve.
Crossed.
sometimes the way the vessel is dissected, the balloon will fit. But this is a huge balloon.
But semi-compliant, so not
potete
a
dare la
non-compliant
cuffia a
balloon.
Colombo? La mia gliela passate a Colombo.
Okay, I think it depends on if I speak loud.
Can you hear Dr. Colombo?
Can you hear when I talk? Or do we need another microphone?
Can you hear Dr. Colombo?
Yes, Colombo,
Okay.
welcome to you all.
Yes, sir.
Hello, Colombo, can you hear us?
Yes, I can hear
Yes,
you very well.
we are welcome you
I'm
all.
here. Let me
7:10.
put some lead, so because otherwise they say that I am not in good shape. They complain. Aspetta che metto.
Negative.
Buongiorno.
Ok, stop. Questo è, sì. Tutto bene?
L'avete fatta poi la
No,
clip
no, ci
a
vuole
quella
ancora un po',
signora
ma
un
viene
po'
benissimo.
di
Dobbiamo avere un po' di
Dambra lì?
pazienza qua.
Dambra?
Patient is doing
Una
well.
signora che doveva fare la clip.
No
L'altro
chest
ieri?
pain. And this is here with
Ah,
impeller
perché l'ha
device in place, independent,
E
obviously,
come mai non
of
c'era lei?
valvuloplasty done or not. You really work very calm and
Ha cambiato
much
pettinatura,
better
non l'ho mai
compared
vista.
to much better compared to a okay, riempi.
Sì, vado io a fare i commenti. Ok. I put the LED, so it's better.
3.528, okay? We like a luminous stent in the LED. Thank you.
So what do you think of you didn't do anything on the diagonal?
Yes,
or
we
you
did.
dilate? Or you did a kissing?
2.5 on the
Diagonal. What do you think? It's okay. It's not so bad. I will bite the bullet and wait to do 2 stents.
Because also, this is an elderly patient.
Yeah, dual antiplatelet therapy.
We want to do short. He's not fibrillating, so this is not a triple anti. So
But
we don't want to do too many
I
stents.
think we can wait. And it's really is not an ideal anatomy for T-stenting, but we have done some T-stenting in these 60-degree angles.
If not, we do a culotte, because it's
Yeah,
really
you
huge.
can
It's
do a
huge. It's
culotte.
huge.
But let's see. Because I'm sure you can get away with 1 stent. I'm sure, I hope.
On the LAD, then we have
Yeah.
the left main and the third.
Left main is critical.
Mm,
Yeah, I will leave the left main.
we'll see.
I will do a follow-up in 5 years.
No, he has to do TAVI.
Yeah, after the time.
Ah, okay.
5 years.
And
5
being
years.
82 years, having LV ejection fraction
Colombo,
20%.
really you want
5
to
years
for
is
follow
enough.
5 years or 5 months?
So are you doing
Pardon?
a valvuloplasty later on?
Yes. I did
Okay.
not catch your question, excuse me. No, he will get TAVI or today if there's a problem, or very soon in 2 months.
So this is an abluminous stent.
Yes, okay, inflate.
Is it diabetic,
12.
this patient?
It is 328,
So it
3.5.
This stent works also in
So this is-
non-diabetics? I thought that was only used for diabetics.
negative, mi date un 375 semicompliante 8, non compliante 8,
What size is this stent?
3.5. No, non compliante 8.
So
What pressure you
375
give?
non-compliant short balloon.
To do the pot,
Do the pot.
and then we do a film, then we could rewire and do a film or whatever.
With
What do you think about these bifurcations? How many in the panel would have done 2 stents from the beginning, or even after pre-dilatation cross over to 2 stents?
No, Dr. Colombo.
Can you hear?
Considering the age, clinical scenario, left ventricular ejection fraction, we should still now we are considering single stent.
Single stent. They say single stent. All the panel is saying because
stent.
Unfortunately Dr. Colombo cannot
But
hear
Dr.
you.
Reimers will repeat.
Yeah, okay. Here we go only 10.
Post dilate. You are post dilating
3.75 non-compliant balloon.
375.
Okay, 10. 375, yeah.
Okay.
Negative. Not so high pressure here. And with very high pressure we do the pot, okay?
Bifurcation.
Okay, go here to 22.
Yes, this is the pot.
Yeah, it's a single balloon pot and distal, but you know, we have to be
okay.
critical.
I think it's okay. You grade the size by the pressure. The bigger the pressure, the bigger the size.
Okay, if we do not want to stent the left main, I want to do IVUS because I want to see the area of the left main.
Okay.
Stai già preparando.
What will be, Antonio, your cutoff area to stent the left main? In this patient? Okay, I agree. 5.5. I believe it's important before doing IVUS, decide at the beginning what you do if you find A and what you do if you find B. So you have to declare at the beginning your behavior. Recrossing was quite fast.
Without a torque device. Oops.
This is a safety wire with a band, is nice. Bernhard, did it ever happen in your experience then a side branch wire did not come out?
No, at the end, nowadays, less and less. In the old times, you know, that we had to go with the balloons and sometimes under the stent, but now any wire goes down. Okay, I think it's good for angiography. Now we have this Tion in the side branch, the green one, okay? Flush, please. Fill up the catheter, okay? No, I don't do nitro because there's still aortic stenosis, so even though there is impella. Okay, I think there is a distal dissection and a side branch dissection.
The side branch is a little bit compromised.
Yes.
Quite a bit compromised.
Distal dissection is also probably due to the oversize. Distal vessel is not 3.
And distal to the stent, I think you need a short stent.
Yeah, a short
distally.
stent.
Not too big.
225.
Antonio Bernhard.
5.
This is
Yes.
Antonio. This is Bernardo. Ciao from Bangladesh. I've just joined the panel, so I wanted to ask you, what do you think? Because there are two different dissections actually. One is related to the stent, which is just this to the stent, and the other one is on the side branch. So
excuse me, Bernardo, they cannot hear you.
Let's dilate the diagonal also.
Yes, okay.
But you can put a stent distally, so you
So we
take
fix
care.
that distally and then, okay.
Short stent.
I go have a look where the abluminal stent. 24.
And which is your approach for the diagonal branch now? Just to be conservative, or using drug cutter balloon, or what?
2,5. Okay, yes.
Qui si va sul lungo.
For distal dissection, probably we have to think another stent.
Yes, that we put now another stent. Now we don't oversize. And you see the
2.5.
disease is quite long. We use a 2.5, 25, and then we post-dilate with a
Yes,
3.0.
that's right. 2.5.
Maybe the 3.5 was a little bit generous.
A little
the
bit
first
higher.
stent.
That's
You
right.
are,
That was the cause of dissection.
you are right.
But maybe if you follow the Murray law, 3.5 approximately, maybe 3.0 distally.
Yes. Yes.
Then we do kissing, and then we decide if we have to switch over to a culotte. Bernardo, can you please, repeat your question?
Yeah, we all agree that distally to the stent, when you have metal and you have a dissection just after metal, you should fix it.
Yes.
And we were discussing on which is the best solution for the diagonal branch for being conservative, also considering the sickness of the patient and not to put too much metal. So which is your suggestion for it?
We completely agree.
What did he say?
Roberta? Roby? Puoi scambiare I nostri due microfoni?
And for the side branch,
You
Ma
take
tu non lo
this
senti?
one. Io li
No,
sento.
ma poi mi
Okay.
ripeti.
Okay.
Poi mi ripeti.
No, Bernardo Cortese, Antonio is telling, because Antonio does not get you.
Dr. Colombo, and for the side branch,
Okay.
But
do you want to...
Bernhard will repeat some questions.
Yeah, tell us a question, I will tell Antonio, okay? 1 second.
He has the microphone.
Okay, go. Un 3-0 non compliante. Negativo. Now we post-dilate with a 3.0, so we are not too aggressive. Then we go into the diagonal. Can you repeat the question for Dr. Colombo, please, so I can give it to him?
Now you are going to stent the distal dissection, and we totally agree.
Yes, we did already. The stent is in. Now we post-dilate the stent.
The question was if to be more conservative for the diagonal branch, maybe putting some drug on it by means of drug-coated balloon in order to fix.
Yeah, I heard your question. I will definitely first do a kissing inflation, because the angiographic result now is still not good enough to go for drug-coated balloon. So I will do first an inflation on the diagonal and then reevaluate. I think we can still give a chance for a drug-coated
Mi dai
balloon.
un semicompliante 2.5.
Professor Colombo is saying
Nuovo.
that before using any type of drug-coated balloon, you have to prepare perfectly the lesion, and still this lesion needs to be better prepared.
Yes, I don't.
But
I'm not going to use a drug-coated balloon unless I have an angiographic result that I consider acceptable.
With a nice dissection.
But
Or maybe even without. But,
Dr. Reimer, but you see the side branch dissection looks ugly.
Yes, but looking ugly does not mean it is ugly.
but in these patients with low ejection fraction, impella type, my threshold to stent is lower.
Yes. And
Because
that is why
also
you wanted
the
it.
age. So, I think you have to take these considerations into place also.
That's right,
10.
Dr. Colombo, and that is why we
pressure-
have decided to single
Yeah.
F- 14
But
both.
let's see what they are doing kissing. So which size is the LED balloon? 3.0.
Two, in the
And the
side branch,
diagonal? 2.5. So,
Negative.
and this is a gentle kissing. How many atmosphere?
Diagonal balloon is 2.5.
2.5, 14 on the diagonal,
Yes.
3.0, 14 on the LED.
LED.
Gentle kissing.
Because
gentle
I was
kissing.
not sure to get with a bigger balloon into the diagonal. No, we did not know
I
how.
think 2.5 is appropriate.
And diagonal
Let's
balloon is
see
a
the
drag-coated balloon, Dr. Reimer?
Pardon?
2.5 on the diagonal and trio on the LED.
Regular balloon.
Regular balloon.
Semi-compliant balloon. Gentle kiss. Let's see.
We go a little left, so we have another impression. No, too much. Perfect flow.
It looks good.
Yeah.
Give me 3 flow.
LED is okay. I would do a drug-coated balloon now.
Yes. We also suggest.
Reimer, can you,
You agree?
show us allocranial view?
As because patient's left ventricle ejection
This
fraction
is cranial view, LAO.
as because
One is just AP cranial. I don't want another view.
I mean,
we
yeah.
go IVUS.
It's not
it would shoot the ostium very nicely, but as because left ventricle ejection fraction is very low. So many dye is not.
I will not object to do a T-stenting, short stent. What do you do, Antonio?
No, we suggest to have one drag balloon in the side branch. DCB.
Drug-coated balloon in the side branch. Okay. We do IVUS to the side branch
IVUS.
because we have to do IVUS anyhow to see also the left
dissection
vein,
loops.
if we can leave it there or not.
That's right.
So we had to open, and then we'll decide the fate of the diagonal. So normally it's the other way around. Antonio Colombo says no stent, and I say stent. This time, okay, it's good.
Yeah, but Bernhard, you got a winning point because if you do imaging, you will be forced to stent it.
I don't know.
No, I don't know. I don't know.
I have also to see the left main.
This is not an ideal situation for cool-out because there is a big mismatch between the side branch and the main
No,
branch.
not so big.
No? 2.5.
Okay.
I think.
Pull back. We
So
are
the
deep in the
vessel
diagonal.
is 1, 2, is a small trio. Small trio. Some plaque, but not bad. Lumen is fine there.
It's
Here it
getting a
gets bigger.
3.5 here,
It's a
so
little
the
bit
mismatch is not.
ecstatic.
You could see a nice dissection at
Yeah.
9 to 12.
I would say that the section is very short, very focal. You can take a chance.
Here was 3.75 post dilated. The vessel is bigger, but I think it's.
I think you can do DCB.
And this is left main here. Okay, we have to measure the left main. This is quite tight.
Can someone measure the left main?
Stop. We file left main. Okay, give me your thoughts, please.
Yeah, we agree that the DCB there is, since the dissection is focal.
I will take
and the area is
I will
good,
take
it's
a
good
low
choice.
pressure DCB trio, but
Yeah.
not going too distally because Macorto. I will not protrude too much in the diagonal because the diagonal distally gets a little bit smallish.
So a short trio, and what type of DCB are you going to use now?
Magic touch, we only have this one. of
Tocco
course.
magico.
Only magic touch, yeah. And are you using it alone or by means of another
What
kissing
is
balloon
a
inflation?
what is a vessel?
No, and then we do a final
So
kissing.
the left main minimal lumen area is 5 square millimeter.
That's too small. Because we have to put a TAVI over the top. Now we are here. We
Yeah.
have impeller. So we decided to treat also the left main. Before this, we have to treat the distal circ, which is dominant and has a focal lesion. I don't know whether we have seen before. No, we saw yesterday. We didn't give you a shot of this.
And Bernhard, are you going to treat it now, or would you think to postpone the procedure to a few days?
No. We have the impeller in now. We do everything. Okay. We do valvuloplasty, and then he'll get TAVI in 2 or 3 months after the summer.
Okay.
È molto maltrattato. Speriamo che non si rompa. Yeah. Maybe we should have put the other balloon afterwards. Now we will not scratch drug off the balloon. It's nicely in. Bernardo, tell us about the something regarding the technique of the magic touch.
Well, you are anticipating my talk, which will be here in 7 minutes. But, we didn't agree this, but actually it was perfect. But Magic Touch is the first DCB eluting sirolimus to be marketed in Europe and has a very improved deliverability thanks to its technology.
Only Magic Touch, non-kissing.
So it is easy also to do kissing balloon with 2
DCBs. Orologio. Yes.
Which was not possible before with the paclitaxel
balloon. No, lui fa solo drug-coated balloon.
How long do you inflate in coronaries generally?
Well, a minimum of 30 seconds, but if I have a nice dissection like this one, I would suggest to keep it inflated for more time. If the impeller will do its job to maintain the pressure.
Patient is tolerating with the impeller.
But if you occlude the coronary, he may still have pain.
What is the flow?
Ha dolore al petto?
It's a 3.3 liters, excellent. 3.3 liters impeller, excellent.
45 seconds, we go for 1 minute, then we do, you can start to do the kissing.
Okay. Can we see the blood pressure for 1 second? Just to
blood pressure is 140.
Oh, great.
No,
no, a little less.
Little less, 120.
Still enough. Negative?
Sometimes 130.
ACT?
Fa un freddo qua, ma non avete freddo qua? Non avete freddo? No? Ah, oggi c'è la Casillo che imperversa.
Big heart, the wire in the LED is quite deep. Okay.
And for the left main, which is your strategy? Because actually I just saw this projection and not a caudal one. So
well, you tell me. So far, all the suggestions, we followed you. So I'll show you another projection, which we haven't done today. We just look this one, but we do the one.
Just to see how is
we had the baseline, so.
Yeah.
Dr. Reimers, we are very close to ending of our session.
Okay. So I show you the left main strategy. Then I show you. He woke up. Hello, ha dormito bene. Siamo ancora qua. Bravo.
One stent on the left.
One stent.
Yeah.
And now in the left oblique, Roberta, attenzione. Left oblique, I just show you the lesion of the, the lesion of the dominant circ.
Eleocaudal.
And can you?
Cranial.
Piccolo test.
Circular osteum দেখতে চাই, এটা বলে।
No, it's not good one. Right.
Oh,
Giù le mani, lungo il fianco, grazie. Bravo, bravo, ti sei svegliato. Small test. You see this distal lesion, do we need to treat it? Or the inferior wall is depending on it?
Yeah, it's very
I
important.
would say yes.
It's dominant.
Yeah.
Yeah.
Okay, we continue to work. We will take care of this lesion, the distal circ. Then we will take with, we will dilate. Maybe with a balloon, and then we decide whether we need to put a stent.
Yeah.
You would not treat, Antonio?
Ma puoi fare una obliqua sinistra che non ti piaceva, quella obliqua sinistra craniata.
Yeah, we did before, I see.
You did?
This is a little bit left, not
No,
much. Okay,
proprio
we try.
sinistra.
I try. Of course, we can also leave it alone. What would you do with this circ?
My feeling, I will leave the circumflex alone. It's a distal,
Small test.
not a nasty lesion. Vediamo. I will leave it. It's a trifurcation. It's a pain in the
It's a
neck.
trifurcation. It's a very
I will
nice.
leave it alone. I will do a check in 5 years.
Yeah, I think it's wise because of the patient. Okay, the
I
clinical
think,
history, the age.
It's a long branch, huh?
Yeah, but
The
it's,
PD.
it's
Okay.
not so severe. I mean, it's.
Okay.
I will leave it alone.
We have to decide the stent, the abluminous stent here. I would say a 3.5. Let's go for what we have, 12
Bernhard.
or 18. Okay.
Bernhard, I don't know if we have time, but I wanted to ask you just to let us see again the IVUS of the distal left main in order to
If
see.
Can you
Yes.
show they want to see again? They want to see again the IVUS. Can you show? Yeah, the left main. They want to see the
just to
left main
understand
IVUS again.
if you're going to use
Can you
a
show the
normal
IVUS
balloon.
at the tight point?
Yeah.
So let me. Okay, here.
Yeah.
Here
So,
is the.
yeah, there is a
There is
calcification
some calcium.
down.
Some
Okay,
piccolo test.
here.
Yeah. So how would you approach this
Piccolo
single stent?
I think one
left
stent
main?
you predilate.
Okay.
Predilatation is always a must. Place a wire in the circumflex.
That's what I'm trying, but maybe I need some more curve. No? Small test whether I'm in a good circumflex. Yes. Okay.
Protection wire in the
How
circumflex.
long the stent?
Reimer, I think it is actually a great case and very complex case. I think you should continue your case. By
Okay.
this time, we have to move for the next session, and we are in the
Okay.
after.
Thank you so much.
After discussing the session,
Goodbye.
we will come back to you to know
Ciao,
the result.
everyone. Ciao, Bernardo. Thank you to Bangladesh.
Great case.
So left main, no circ, and valvuloplasty, and patient goes home tomorrow, hopefully. Fingers crossed.
Okay, thank you.
Great.
Congrats
Thank
to
you
all.
very
Ciao,
much.
thank you.
Congratulations.
Ciao,
Thank you
ciao.
very much.
Thank you.
Bye bye.
Thank you and congratulations.